Hi, everyone.
Well, welcome everyone to our monthly seminar of the Neurohumanities Network. As you all know, we are a group interested in the intersection of the humanities, the arts, and the neurosciences. Go to the next slide. And before starting, we want to express our gratitude to our sponsors. It's been the second year now that we are supported by the Arts and Humanities Initiative at Harvard Medical School. And we also recently were awarded with a grant from the AAN that's focused on DEI innovation. We're very excited and humbled for this grant, and there will be great things to come. We have a whole team. The Neurohumanities Network are you all, but our team works very hard in bringing these efforts. And we have both a blog team, a newsletter team, a website team, social media team, and outreach. And we absolutely welcome anyone who would like to join us. The next slide. There are many ways to connect with us. We have, as you know, monthly virtual seminars and booster sessions. We have a YouTube channel that serves as our seminar archive. And if you miss any of our talks, we're excited for you to join us there. We also have a presence on Instagram, on Blue Sky, on X, on LinkedIn, and then you can, of course, reach out to us via our email. We also have a newsletter and a website that we encourage you to visit, and you have the QR codes right there. Next slide. I am so excited for today's seminar. Alexa Lesenskyj is a former member of the Yale team. She completed her residency in child neurology just last year. Before that, she had received a medical degree from Rowan University School of Osteopathic Medicine, and she's currently now a Pediatric Movement Disorder Fellow at the University of Rochester. And I was so excited when she gave this talk last year, so much that I knew that we had to bring her to give the same talk to us, or a similar version of the same talk. Alexa really loves pediatric neurology. She loves movement disorders, and she also has a passion for creative writing. And these passions really come together in the field of narrative medicine. So I'm really excited for today where she will talk to us about the art of storytelling in movement disorders. Without further ado, take it away.
Well, hello, everybody. I'm really excited to be here giving this lecture today, and thank you for the kind introduction, Mattia. As described, I'm a few months away from completing a pediatric movement disorder fellowship at the U of R. And what I find so enjoyable about movement disorders as a field is kind of a need to understand how people move, live, and function in their day-to-day life. And there's a pragmatism to that approach that is just incredibly fulfilling. To be good at what we do, we have to listen to stories and translate these into creative solutions to problems. And when you add the layer of caring for pediatric patients, you suddenly have this beautifully layered and woven picture with more than just one patient and life to consider. And we have this unique privilege of considering multiple perspectives and impacting change in perspective from the very beginning of the story many times. So therein lies the inspiration for this talk, um, embedded in which is kind of this idea of narrative medicine, as Mattia alluded to. So, narrative medicine, for anyone that is less familiar, is the idea of using writing about either your own or a patient's experience or story to infer meaning. Importantly, often as a way to uncover optimal therapy for that patient. So, Rita Sharon is the modern founder of this term in about the early 2000s. And like Sharon, I would argue that really to excel in our field, not just as neurologists, but really as physicians, you have to master narrative in medicine. So, no, I don't necessarily mean that we all need to be prophetic writers, but we do need narrative competence and knowledge and sort of this ability to synthesize and act on the individual human experience as it pertains to disease. So, this in this lecture, I hope I'll show you the sort of historical importance of narrative, and in the process, teach you a little bit about the origins of storytelling and movement disorders and how they influence our practice today. For structure, I'm going to take you through two different phenomenologies and start by reviewing their basic historical origins through more modern times, and then based on narratives that were written at those times and different points in time, I hope to give you some of that perspective, and then I'll share my own experience with narrative and the particular phenomenologies that I'm going to focus on, along with uh, my perception and perspective on potential future considerations. So the connection to movement disorders, although the phrase was coined in the early 2000s, narrative medicine started much earlier, which is painfully obvious if you read the earliest descriptions of patients with movement disorders. For context, I put a few terms up here and the timing of their first use. I mean, you could see things like tremor to tremble or to fear. Already a phenomenology was being related to an emotion or a description of something people were seeing. The term tic originated among horse breeders originally for the twitching and jerk-like movements seen in horses and then likened to what they were seeing in patients. So already kind of the start of narrative medicine. So for our first phenomenology, let's start with a story. This was a patient I saw in residency, and his exam was described as follows. Um, Mostly summarized as sort of this pretzel-like twisting, intermittent writhing, poor sense for where he was in space, suddenly pick back up again, abnormal movements that would suddenly pick back up again, and then almost as though his fingers were playing the piano. Now, there's a lot to unpack there, and if you read the whole note, there was even more to unpack. But I think we all kind of get an idea of what this is, and that is chorea. So the first descriptions of chorea date back to Central Europe in the late Middle Ages. Early references made appearances as early as 1021 to like the mid 1600s. The first historical written account, which there's an image of up here, went as follows. On Christmas Eve in 1021, 18 people gathered around a church in the German town of Kolbig and danced with wild abandon. The priest, unable to perform mass, because of the irreverent din from outside, ordered them to stop. Ignoring him, they held hands and danced a ring dance of sin, in quotes, clapping, leaping, chanting in unison. The enraged priest, recorded a local chronicler, cursed them to dance for an entire year as punishment for their outrageous levity. It worked. Not until the following Christmas did the dancers regain control of their limbs. Exhausted and repentant, they fell into a deep sleep. Some of them never awoke. So this was followed by descriptions of similar events in 1374, 1518, verified with dozens of accounts dating back to those exact years and times. And historians agree that this was sort of they called it an involuntary dancing mania, hypotheses ranging from ingestion of mold or ergot that grow on stalks of rye and can cause hallucinations, spasms, and tremors was one of the thoughts, all the way to psychological distress. Now, remember, this was the time of syphilis, leprosy, and plague, not to mention high grain prices. So lots of stress. Um, Shortly thereafter, Paracelsus solidified the term chorea. He called it chorea Saint Vitus, believing that if you touched the saint's relic, the movements would stop. He also distinguished between three other types of chorea, characterizing them as, quote, the disease that deprives man of reason. And so these were the three types. Chorea imaginativa was arising from imagination, lasciva arising from sexual desire or passionate excitement, and then naturalis arising from physical causes. Then we move into a more familiar time frame, that of Sydenham in 1600, 1684 or so, and he described a few types of chorea, most notably what we now call chorea minor or Sydenham's chorea. He wrote, there is a kind of convulsion which attacks boys and girls from the 10th year of time in puberty. It first shows itself by limping or unsteadiness in one of the legs, which the patient drags. The hand cannot be steady for a moment. It passes from one position to another by a convulsive movement, however much the patient may strive to the contrary. Before he can raise a cup to his lips, he does make as many gesticulations as a mountebank or snake, since he does not move it in a straight line, but has his hand down aside by the spasms, until by some good fortune he brings it at last to his mouth. And then he gulps it off all at once, so suddenly and so greedily as to look as if he were trying to amuse onlookers. And you can see here a photo of one of those classic textbook photos of Sydenham's chorea. Moving on to some of the other giants in medical history, in the 1800s, Charcot assigned his student Gilles de la Tourette the task of, quote, sorting out the chaos of the choreas and how ticks fit into that picture. This photo demonstrates what they called occupational chorea at the time associated with hysteria. Charcot comes in again and cites these as repetitive swimming or hammering movements, the alternative to, quote, organic chorea being more irregular and unpredictable. So then in the early 20th century, you have Osler coming in and sort of colorfully defining chorea as a syndrome. And this is when the landscape sort of starts to take shape of a similar version of what it looks like today. And so I put this here not so we read the tiny text, but mostly to demonstrate the sort of the enticing title and the vividness of the title, really. He titles it History of Fright and Violent and Incessant. He writes things like they are so strong, the most powerful restraints fail. So violent are the movements that she had frequently injured and bruised herself. And she several times inadvertently struck her mother. She's intelligent, sleeps well, even soundly, the movements ceasing completely. Moving on to the better known Huntington, who published on chorea, he wrote, the will is there, but its power to perform is deficient. The desired movements are after a manner performed, but there seems to exist some hidden power, something that is playing tricks, as it were, upon the will, and in a measure, thwarting and perverting its designs. And after the will has ceased to exert its power in any given direction, taking things into its own hands and keeping the poor victim in a continual jigger as long as he remains awake, generally, though not always, granting respite during sleep. And of course, then we get to Gower in the 1900s, whose description is kind of closest to the framework we have now. He talks about things like senile chorea, which is probably vascular or late onset HD. He talks about maniacal chorea with psychosis, most likely related to systemic lupus, or even Huntington's. Tetanoid chorea with dystonia, probably Wilson's disease. Functional chorea, a psychogenic movement disorder, and then recurrent Sydenham's chorea or paralytic, the paralytic version. Gower made this framework as part of his experience seeing patients at Queen Square Neurologic Institute in London and documented over 120 patients with chorea. And at the same place, Queen Square, not long after, in the mid 1900s, Samuel Kinnear Wilson made a silent film of several movement disorders, including Sydenham's chorea in a child, which I'm going to share a snippet of here. And there is no sound, in case anybody is wondering. The Movement Disorder Society put out has sort of a database of old historic videos, so I encourage you to check that out if you're interested. That's where I found this one, and they added in the captions later, of course. And I love that flycatcher tongue, narrative medicine at work. So fast forward to 2023, my residency continuity clinic, where the original story came from. The following referral arrives. We had a 3-year-old with global developmental delay, hypotonia, optic atrophy, feeding difficulties, and the classic quote unquote concern for chorea. The patient was full term, spontaneous vaginal delivery, uncomplicated, and neurology referral came at about 6 months, but it was for hypotonia initially, and not to where I was. Over the next 2 years, the story that unfolded was one of profound cognitive delay, severe axial hypotonia, continued chorea, failure to thrive, then G-tube placement, along with optic atrophy and blindness. And prior to arriving at our clinic, he had an extensive workup. It included, was not limited to normal CSF studies and metabolic testing, an EEG that was normal, a brain MRI that was really quite nonspecific, just with some T2 flare hyperintensity scattered in the subcortical white matter. And then he had some genetic testing, of course, with whole exome sequencing that was abnormal. And it showed maternally inherited variant in the ATP8A2 gene that was likely pathogenic, and then one that was paternally inherited, but this was an invariant of uncertain significance. And so the outside hospital geneticist, fairly so, felt that the result was not technically diagnostic because there was a variant of uncertain significance and there was recessive inheritance in this gene. So mom was really seeking answers and a second opinion and really just wanted to understand the potential disease course and what she could expect for her son, at which point he landed in our clinic. So, how do I counsel this mom? Well, as we all would do, go back to the narrative. In further review of the literature, I found a case series that highlighted 11 patients who had various biallelic mutations in this gene, some of which had been confirmed pathogenic, but many of which were actually quite similar scenario to my patient. None the exact same mutation, though, but many with VUSs. So they describe children who develop a global developmental delay in early infancy and have these core features that I've listed here. Obviously looks quite familiar. Looking a little deeper, this gene encodes for a protein that is highly expressed in the brain and highest in the cerebellum. So if you remember my patient reaching for a toy as though he, quote, doesn't know where he is in space, where biochemistry meets narrative. At the end of their case series, they highlight that chorea is probably one of the important distinguishing features in patients with this particular scenario of variance. And herein lies the modern importance of narrative and movement disorders, and specifically pediatric movement disorders. Said differently, the importance of clinical phenotyping in medical literature. There is value still in a case series, and in particular, one that includes meaningful descriptions and exams. So I will share this video. This is not my patient. This is from the case series that I found, and it looks remarkably similar to my patient, who I unfortunately don't have a video of. And so what this case series did beautifully was pair the videos with their narrative description of the patients, which, like I said, was remarkably similar to the movements that my patient had, and really helped to provide some clarity for this mother, even though there was still a little bit of uncertainty regarding the diagnosis. So, just as important as the physician narrative about disease is that of the patient, which is, I'll say, a little bit harder to track down when you're looking in the literature, but not uncommonly, we get to hear narrative from physicians about their experiences as patients or family members of patients. I particularly like this poem by Dr. Ramos and her experience with chorea in the context of family members with Huntington's disease. And I'm going to read it because it really is quite powerful. She writes, I am a mother. I used to be a wife. I am not sure if my son remembers still. Maybe that is better. I have one child. My son is 34. He lives with me. He has no wife. He decided long ago not to have children. Huntington's used to be just a town in Long Island or a beach in California. When his father was first diagnosed, my son and I were both afraid for ourselves. How do we survive? But we made do. Then the genetic tests, those so-called blueprints of life. Ha, the blueprints said my son would have the disease too. My son and I were both afraid, afraid in the name of the Father and the Son. We see the small jerks, the subtle funny movements that probably went unnoticed with my husband, and my son would look up at me with the same stare he used when he was 3 about things he did not understand. I raised a brave son, a soldier, who held his father's hand through bedbound pneumonia and even jokingly said, "Do not be afraid, I will soon follow." But I know he is afraid. He cried when he kept on falling, impulsive, as the therapist described him. It could not be farther. My son has always planned his life. Living will is done. For a man, a good man, who told me, Mama, if I should kill myself, know that I put up a hell of a fight, for I know the grief that it will bring you. It will not be him who kills himself. It will not be him. His doctor sees him once a year. There is nothing they can do. I see him every day, and more I see less and less. What plague is this? What protein? A protein in the name of the Father and the Son. My God, I accepted widowhood. I am a mother. Do not let me be in vain. But then my boy's words come back to me. Mama, when the time comes, I will tell God to take care of you. He will take care of me. Let me now hold his writhing hand for as long as I can. It's hard to follow that one, but really beautiful description of chorea there, not necessarily of a pediatric patient specifically, but I think it really embodies everything that is kind of woven through chorea and the descriptions throughout history. So patient narratives exist like this for numerous conditions, and as all of you know, not just limited to neurology in the field, but certainly we have a pretty big presence in the field of narrative medicine. And if you haven't explored these sort of pieces, whether it's poetry or just sort of written prose, I highly encourage you to read what your peers are writing. I suspect that I don't need to tell you because you're here and part of a neurohumanities group, but it's powerful and a perspective changing, in my opinion, and a crucial part of what we do as physicians. I'd like to use this next narrative in the form of a poem to introduce part 2. The second phenomenology I'm going to discuss is dystonia. Um, this one's a little shorter. It says, when dystonia scrambled my brain, signals like a virus, corrupts a hard drive, I was sure I could not spend 10,000 hours retraining my brain to play the flute in a new way. But when I heard that the luthier and his son restored the Holocaust violins to free their lost voices, I changed my mind. If I am silenced, you would not miss me, but the way my vibrato on the first C sharp of La Après Midi d'un Fan conjures up a sultry summer afternoon, the way your hips swing when I play a tango, the way you hear whales when I close my lips around the mouthpiece to hum Voice of Wales. The original 10,000 hours I will tick in reverse, a feat as tricky as learning to ride a backwards bicycle until once again I can curve quiet fingers over the keys, whistle my lips to laser the tone down the silver tube, your body ringing in sympathetic vibration. So now for the personal narrative example, and this is a patient that I saw early in fellowship, whose exam could be summarized with the following phrases. So, and in full disclosure, he had a mixed movement disorder, which was true of the first patient as well, but the predominating feature was dystonia. So he had stiffening of the body when walking, posturing that takes on a twisted fashion, worse when he is moving, difficult with writing, suffered several falls. So dystonia is a more modern term when compared to chorea, but torticollis specifically dates back to the ancient world with early mentions by Hippocrates, for example. And then in the medieval times, disabilities often appeared in religious art, and you can see an example of that here. This is a set of painted figures from El Borgo de Osma Cathedral in Spain. The people look as if they have cervical dystonic postures, head tilted to the left, and pained facial expressions. Another example, which I couldn't find a good picture of, are legal documents that are written by French scribe Bernard Blancard between 1297 and 1343. He wrote, "The scribe's right hand shall be liberated from the gravity of pain," and dated handwritten documents preserved sort of show the progress and deterioration of his script with a very clear multi-directional jerky tremor that would be suggestive of a dystonic hand posture. The first known use of the word torticollis was by the French author Francois Rabelais in his 5-book series Gargantua and Pantagruel in the mid 1500s. It's a satirical comedy and it's praised for its wordplay and vulgarity about a giant and his son. And the author describes how the beheaded character was healed from a soft concoction to avoid a wry neck, which translates from the French term, quote, torticollis. And there you go. Here, the term was used more as a satirical reference to the head bowing of religious hypocrites, but it stuck and made its way into medical terminology. And these are some images that were made in the context of that story, that book. In the Enlightenment era, Samuel Kinnear Wilson comes in again. He used this verse by the poet and dramatist Paul Scarron as an epigraph to his textbook chapter on torticollis. He writes, "My poor body is shortened, and I have my head on my ear, but it suits me marvelously, and among the stiff-necked, I pass for one of the prettiest." So as we begin to classify dystonia, we see more familiar terms arise, and a few old friends make some cameos. We have Meg come in around this point and coins the term gest antagoniste efficace, or the sensory trick. Originally, he felt sufferers had a lack of psychical equilibrium or, quote, fecund imagination, feeling it was psychiatric in nature, but then flip-flopped when he saw many survivors of something called von Economos encephalitis developed it. Von Economos was a global presumed viral and maybe the flu epidemic in Europe in the early 1900s that affected the midbrain and the basal ganglia. Charles Bell describes a different epidemic of writer's cramp in clerks of the British Civil Service in 1830. And then even Duchesne, Erb, and Romberg get involved in various ways and support the idea that dystonia is of an organic cause. In popular culture, Dickens' David Copperfield has several examples of dystonia. In the Victorian style of writing, it was really common that physical attributes were used to call attention to unattractive features of a character's inner self. For example, there was a vain character that would, quote, carry his head on one side as if it were a little too heavy for him. The harsh and dictatorial headmaster, quote, had no voice but spoke in a whisper, suggesting a spasmodic dysphonia. And then here we have published photographic image from of a movement disorder coming from the Paris Neurologic school, and many of them came around this time. And here we can see Modigliani's painting demonstrating gest antagoniste, or that sensory trick. Following this, we have Sagawa providing the first description of dopa-responsive dystonia. We're in 1971 now. And then Fawn and Marsden help out in the 80s and further characterize dystonia as a neurologically localizable problem. I'm going to play another historical video for you here. And again, there's no sound. So in 1971, Sagawa wrote about a girl suffering from a walking difficulty that worsened towards the evening, and she had a female cousin that had the same symptoms. Dr. Sagawa decided to try levodopa, which had recently been discovered at that time, and it worked remarkably well. And you'll see that in the video in just a minute. These are some before videos. So he described two types of dystonia, a postural type that typically occurred at younger onset, 6 years of age, with initial symptoms mostly were unilateral pes equinovarus that extends with time to the other limbs and trunk, and then more of an action type that started at 8 to 10 years, and this had dystonic movement of one of the extremities or the neck, more of an action retrocollis. I think we're coming up to the after treatment now. You can see a remarkable improvement. So while we are still understanding the complex mechanism that underlies various dystonias, Sagawa's discovery of dopamine responsive dystonia provided us with a huge clue to understanding the mechanism and possible treatment. And he really did so through narrative notes. This led to the hypothesis that is shared by more than a few pediatric movement disorders that levodopa may work for other types of dystonias. Move along here. So that takes me back to this experience that I had with a pediatric movement disorder patient in my fellowship. So often in pediatric movement disorders, we're dealing with the ultra rare disease, many of which don't have a name, and even if they do, no clear treatment, and many of which have debilitating and function limiting symptoms, most importantly. I'm going to play this video. I first met this 9-year-old boy when he was establishing care for his dystonia. And even though his underlying disease was actually a hereditary and progressive ataxia, the quality of his life was and is significantly impaired by the dystonia. Walking, writing, playing are all impacted. He had been tried on several medications, and really the only one that so far has seemed to provide any sort of relief has been levodopa. Now, it's not as robust of a response as in Sagawa's dopa responsive dystonia, but this principle of applying the narrative to help those with rare disease to positively impact quality of life is really at the crux of what we do, especially in pediatric movement disorders, in a field where dealing with the rare is quite common. So understanding his story really helps us to make a safe and informed choice, even when there's a paucity of literature in the field. We apply the lessons we've learned from others and their narrative to affect change in his life and in others. So back to the future, where does that leave us? As promised, my perspective on the future. We've spent a great deal of time looking back at how narrative and storytelling in movement disorders is still pervasive in our daily approach to problem solving in the field with a mind toward future directions of storytelling in medicine. We have tools like pictures and videos to further add to this narrative. Just like social media videos have taken over as the quote unquote narrative of this generation, it has also begun to make its way into the movement disorder space. There are new AI video analysis programs popping up every day, and I suspect that they will soon be integrated into our medical records and kind of revolutionize the way stories and narratives are passed along. Right now, most of these programs are used in the context of Parkinson's disease and scoring for things like the UPDRS. But when the technology improves, imagine the value it's going to have for pediatrics. Being able to watch a child move freely and openly in their home with AI video analysis, for example, might help to construct a more accurate narrative and gain a better understanding of how a patient's exam and needs change and are impacted by their disorder, a window into what their life is really like. Which brings us back to narrative medicine and my intro. Patient stories or even video clips give us, as providers, a window into their experience. In turn, we can authentically engage with these pieces of the patient's story on both micro and macro levels, and we practice narrative competence. And in this way, we are all storytellers. And that's all I have for you guys.
Thank you, Alexa, for guiding us to these stories and the history, the story, narration, and all of that. I'm gonna open the floor to anyone who has any questions. Feel free to unmute yourself or raise your hand. Jonathan Newmark, are you trying to talk? Well, I'll start off by asking you a question, Alexa. What first interested you in narrative medicine? How do you practice narrative medicine nowadays?
Yes, that's a great question. I think my first interest in writing and narrative medicine probably started when I had to write personal statements for applying to, even for undergrad. I remember being a high school student and never thinking of myself as like the English history person and always thinking, identifying as like a math science kid, quote unquote. And I loved writing that essay to get into college. And then with each time I had to think about crafting those narratives about myself, I realized, oh, wow, this is kind of therapeutic in a way. But also, I'd like to learn more about other people's journeys. And so I started looking for other people's writing about their experience in medicine and so on. And it was kind of self-guided in that way. And now my practice of narrative medicine, in a we're all busy, right? We have limited time, see lots of patients, write lots of notes, but every once in a while, there's those patients that just kind of stick with you. And it's not always clear why, but they're the ones you kind of go home and you just can't stop thinking about. So when I have patients like that, even if it's just like a paragraph, a lot of times I'll just write it down in a free moment. It takes 10, 15 minutes. It doesn't always end in like a formal poem or a nice prose of some sort, but it's a way for me to reflect. And then sometimes I'll make connections between other patients that I've seen, and realize, oh, there's a theme here, and this is something that I'm kind of processing and experiencing, and maybe worth it for other people to think about too.
Excellent. Yeah, I'm sure the story of the personal statement being an approach to self-reflection will resonate with many. We have a comment from Muhammad Hassan, who said, are there any ongoing studies or future directions you're exploring using narrative approaches for movement disorders?
That is an excellent question. I am not aware of any specific studies. There may be, knowing sort of how pervasive narrative medicine is in the field of neurology in general and movement disorders as well. Um, I can think of one historically looking into, and it was less of a study, more of it wasn't quite a support group, but I know there are children's hospitals out there that use narrative writing and reflection as a treatment for tics, people going through tics and Tourette's. Um, and that there have been a few case series and sort of limited, like retrospective studies of how reflective writing has helped those patients and reduced um, tic frequency and severity. So I'm sure it's out there beyond just that example.
Yeah, that's fascinating. Therapeutic narrative medicine. That I love that.
Yeah. Yeah.
All right. Does anyone else have any questions or comments? You have a comment? Okay. Izzy has a question.
Um,
Sure.
Great talk. Have you found certain themes in which how patients themselves describe certain movements, like chorea, you said described like twisting like a pretzel, but dystonia, I feel like it's obvious for us to see, but for example, do patients generally like describe it in a certain way, or have you found like certain themes to which how the patient will describe it to you of how they experience it in lay terms?
Yeah, I think it's much different in children than it is in adults.
Mm.
So in adults, I kind of think about the certain more of cervical dystonia phenotype, and then I think about like the dystonia that can come along with Parkinson's, and and then in the kids in the child world, it's extremely different from that. And I think each of those kind of has various themes to it. What I would say is from a pediatric perspective, if you get a kid with a primarily dyskinetic or dystonic CP, or even one of these rare genetic like single gene dystonias, the common theme is actually usually not a problem with the dystonia. It's how like a motor delay has impacted their function. So if you hear like, oh, in certain situations, the child seems totally fine and they're able to run or walk or do these, they're able to do certain things, but then not others. That often is a tip off to me that we could be dealing with a dystonia that was maybe undetected. And it gets complicated in kids because we'll much more commonly see an official term, phasic or like a mobile dystonia in children, which can look a lot like chorea. So that's a little tougher to parse out a theme. I think in the adult world, there's probably a lot clearer pattern, like the cervical dystonia patient often. "Oh, I could have always had this tremor in my adult life. Things are wobbly. I have some neck pain. That those are very typical complaints. And then oftentimes in the Parkinson's world, and people like Mattia probably see this more than I do, but like I'll always hear the foot cramping at night. I just can't sleep. Not just my feet are restless, but like my toes just curl and I can't seem. So there definitely are patterns there.
Thank you.
Great answer. Hopefully, I'm not mispronouncing this name terribly. Kyla Villa asks you, do you find that writing about your patients helps you process the emotional challenges and also privileges of taking care of a pediatric movement population?
Oh, 100%. In many ways, it is a very selfish practice, in a good way. I say that not in a bad way. I find it helpful for both me um, to kind of work through some of the really difficult things that I think in a busy day we're inclined and really probably taught systemically to just kind of move on, push away, keep going. Um, and like I alluded to before, there are just certain patients you can't do that. It's going to come back. And everyone's a little bit different in how they process difficult cases. And of course, it's another layer of difficult when you're dealing with a child and their family. And so for me, I'm the type of person who I'm not going to process it right then. Maybe 3 days later, I'll be walking to the car and I have a moment to think, and then it'll come to me. It's like, boy, that was terrible, or that, I had this emotion. And that's when the sort of narrative medicine comes up as being therapeutic in a way for yourself. But I also think that it is incredibly therapeutic for patients. And I mean that in a couple of different ways. I think that us as physicians practice better medicine, and we're narratively competent. We're better able to listen to patients when we reflect that way because we do pick up on themes. But I also think, like I was saying with the patients with tics, reflecting on their experience, that if they write themselves, that can be reflective. And if you're interested, it's a little selfish plug. The resident fellow section in the neurology journal we have a section now called Patient Perspective, in which trainees can write an article with a patient. And that was something that I helped to start a few years ago. So if you're interested in that and you're in neurology and you have a patient that you'd like to co-write an article with, that is a venue to kind of explore that interplay.
That is such a wonderful effort, and we'll be happy to share that in our newsletter as well. We have some comments, but I also want to get to Hannah Ross's raised hand. Feel free to unmute yourself and ask your question.
Hi. Uh, I'm pretty new to the idea of narrative medicine. So I was wondering, how does narrative medicine fit into the wider field of medicine? And more specifically, I thought of the conversation in research of qualitative versus quantitative research, and in medicine, looking at issues as more symptoms, like an isolated list of symptoms, versus a holistic treatment, or like a whole person treatment. So yeah, do you find, like, would narrative medicine fit into more of a personal, like, is it a more personal practice for you and for people, or is it more common in rarer diseases like pediatric neurologic movement disorders?
I
Do you
think
have any thoughts on that?
Yeah, I think it's incredibly common throughout medicine, if you look for it and you know where to find it. Once you know it exists, then you'll see it pop up more and more. Neurologists, I mean, I think this whole group, the neurohumanities group, is evidence to the fact that neurologists have always kind of been just conscious of this importance of narrative storytelling, gathering a good history. But there are lots of journals out there. If you're interested, things like Intima, Journal of Narrative Medicine, Neurology has in the resident fellow section, Right Brain, that explores this. And so the more you look, the more you'll find. The Journal of Pediatrics has, I think it's the Journal of Pediatrics, has a piece of my, or maybe that's JAMA, a piece of my mind. There's a version of that in pediatrics as well. So it really is in many of the fields. I would say what I've seen, the like general medicine field, it's quite common. So internal medicine and general pediatrics, and then also in neurology.
Thank you. That
Yeah.
makes a lot of sense as kind of the historical examples you were showing. We might have come from that perspective versus now I think of a lot of biometrics and isolated symptoms. So that makes sense.
Yeah.
Thank you.
Yeah, and Hannah and anyone else, Columbia also has an online narrative medicine group that meets monthly. I highly recommend anyone that's interested to join. Um, so very interesting comment from Jonathan Newmark, who was telling us how he was the first fellow in the occupational neurology of musician at the original musicians clinic in Boston back in 1984. They
Wow.
published what was the largest case study that had appeared up to that time in 1987. And this helped define the modern description of musicians' dystonia. And he adds that thinking back about these patients, what struck him is how specific their stories were. These patients could identify to the musical measure, to the specific rehearsal or performance when they first noticed a problem. And they could describe the problem in extremely fine detail. In retrospect, narrative medicine was both a very helpful and also very easy tool to describe their problems. Coming up with treatments, especially in those pre-Botox days, was much harder. And Dr. Newmark, if you want to unmute yourself and add anything else, we'd love to hear from you.
Well, no, that's it. It's just I never wanted. I didn't expect to be doing movement disorders. I was doing occupational neurology, but ended up doing movement disorders in that. And then I discovered, of course, that nothing is new under the sun. Gowers had described the equivalent thing in the late 19th century, and there were all sorts of others. But what that leads to, just in case Dr. DeArias is not aware of it, that's led to a whole sort of multidisciplinary specialty of performing arts medicine, which has its own journal and has its own annual meeting. I went to the one last year, and it's very heavily narrative medicine influenced. So that's an example of one group. Pediatric neurology is very hard. This one is easier. Oh, by the way, you're at the University of Rochester. Please say hello to my medical school schoolmate, Dr. Ralph Josefowitz, who is one of the finest clinicians on the planet, and I'm sure he would love what you're doing.
Oh, I will.
Well, thank you for sharing all of that. Muhammad has another question. How do you effectively communicate the potential benefits and limitations of narrative therapy to patients with dystonia, and what strategy could be used to manage expectations and monitor progress, specifically and especially to parents?
I think there's probably not a right answer to this question, but I'll give you my first take on it. Um, Embedded in the overall concept of narrative medicine is just getting to know your patients, right? Not only how do they function and move from a movement disorder standpoint in their life, but what are their likes, what are their dislikes, what are their priorities, what is important to them? I mean, to really be a good doctor in general, you have to do those things. We don't always have time, but if you have a patient who you think would benefit from narrative medicine, therapy, whatever you want to call it, I think it's important to do that because I I suspect that only the right person and the right, just like you would select a patient for the right certain therapy, I think there's a certain patient population that's more likely to benefit from this. You really have to be able to engage, right? Like I have, my best friend, I tell her, oh, narrative medicine is great. And she's like, I hated writing my personal statements. That's not for me. Like she loves to hear what hear what I do. She'll read what I write, but it's not for her. So the same thing goes for patient. And I think patient selection, so to speak, when you're considering narrative therapy or narrative medicine is really important. Um, and then as far as like objectively measuring effect, that's a tougher question because I think even when it comes to, for example, dystonia, if I have a kid coming in and we're starting them on a new medicine, we don't even have good tools to objectively say, is their dystonia improved? I mean, there's the Burke-von Marsden dystonia rating scale that we kind of use as this proxy just because it's the best thing that we have. It's a little more well validated in adults, but it's really not that great for kids. We just use it because it's what we have. So I, I don't know that we have a good way to objectively really measure like are things better. But you tell parents that up front. You tell kids that up front. If they really like writing and it's something they're into, get them excited about it, get them encouraged about it. I can't tell you how many kids I've said, oh, there's this opportunity to like, publish an article online if you have an interesting story about your experience. And kids jump on that. They like that. They like writing and exploring that. So whether it directly or objectively impacts something like dystonia, I don't know, but do they feel better? Yeah. And I think that's kind of the point.
Yeah, very well said. That's also where we're so tied to quantitation that we need to
Hmm.
think about also qualitatively how getting
Right.
agency back to narration can do. Great. I think we have room maybe for one more question if there's anyone else that has a burning question. Otherwise, I think we can go toward the outro. But again, thank you so much, Alexa, for this wonderful discussion, wonderful summary of storytelling, and thank you all for participating in this Q&A.
Thank you, Mattia.
All right, Galina, do you want to take us away?
I can, but I actually had one quick question. Is it okay if I add one more? I was gonna wait to see if anyone else had one. Alexa, this is my disclosure. I'm an adult neurologist, so pardon the ignorant question. But I'm curious how you think about the role of developmental movement learning and how that goes awry um, in terms of development of normal like movement patterns if there's a childhood movement disorder. And is there any analogy of kind of like someone who's had a normal developmental movement and then sort of starts to lose that in adulthood, which is sort of, I feel like what we see a lot more is
Mhm.
like the loss of a quote unquote, let's say, normal curve type pattern of movement and how that diminishes. How does that look on the other side when a child has not yet developed what we might say like that kind of normal pattern of movement and how that interplays?
Yeah, I think this is such an interesting question that we really, as a field, don't have any sort of necessarily concrete like way of answering, but I do have some thoughts about it. So I think when children present and have never had a quote unquote typical or normal movement pattern, there's less of an expectation that things will be ever quote unquote normal or typical. But that's from the child's perspective as they grow and form those thoughts. Um, but from the parent's perspective, there's this very interesting sort of grieving process of what they expected their child to be like and the expectations that they had. And that, depending on parenting style, can get projected onto the child. So that's sort of like the biopsychosocial sort of model that I think about that. But from like a purely like movement standpoint, the movements also can look different because if you've never developed a movement pattern, you're more likely to eventually develop contracture. That's an oversimplified example, but oftentimes just movements just look a little bit different, and it's hard to sort of quantify that. Um, but it's different. There's often less compensation or compensation in just a different way. Whereas if you're a kid with a teen onset single gene dystonia, and you had kind of a normal life up until a certain point, um, that's a whole different biopsychosocial model, because then as the child you're grieving, as the parent you're grieving, the experience is obviously different for every individual and how people handle it. Um, but that looks different too physically, because they remember what it was like to walk. They remember what it was like to not have pain. And the compensatory mechanisms are a little bit different. But I don't know if I could say more concretely, like exactly what is different, but there definitely is a different flavor to those two.
Such a beautiful narrative description of the challenges. Thank you so much. Beautifully
Yeah.
said. Well, we are wrapping up. Thank you, Alexa, once again. And I have the pleasure of walking us out the door with a couple of final announcements and slides about some upcoming and exciting opportunities from the Neurohumanities Network. So give me just a second to share my screen and I'll share some final thoughts. But our first announcement is that we are hoping to grow our team. And in particular, we would love to get some help with our social media presence. So if you are a passionate volunteer who wants to make us as famous as TikTok ticks, we need you. Feel free to drop us a line if you're interested in not just design, but really what we really need help with is someone who can organize and schedule our posts, edit videos, and help us with content creation. So we're looking for writers out there. So I'm hoping I'm catching some writers on our narrative medicine talk today to join us. Feel free to send us a line. And if you're not so experienced but interested to learn more, we welcome your help as well. And I'm going to be the first to announce that we're launching one of our kind of, I guess, biannual now contests. So we're calling this one Spring Awakenings, starting now and until the end of April. We'd love to see our community. That's you, all of you, engaging with arts and humanities. So send us a photo, a video. I guess we'll include it to narrative, poetry, or something else about you engaging with the arts and humanities. It could be anything, sketch, painting. There's some ideas on the left. And basically what you want to do is share a photo of you engaging in that with us. Anyone who shares will be entered into a raffle, and one winner will be drawn, and you'll get a little prize. So please welcome spring and welcome the creative forces within you, and don't forget to share those with us. And finally, our next seminar. We've been looking forward to this for several months. We booked it late last year, and finally, April is arriving, but we're going to be having a talk on loneliness and artificial intelligence by Vladimir Bach. So join us next month, Tuesday, April 14th, 8 to 9 p.m. Eastern, and we hope to see many of you there. With that, good night and be well, everyone.
Have a good night, everyone. Thanks, Alexa.